Hello and welcome to this next video. We're looking at a quite niche concept today. This is going to be one of the shorter videos, but nonetheless it's one which is quite helpful, particularly when talking about communication and health inequality stations. So it's quite high theory, but once you get the idea, it's a really useful terminology and idea to use when explaining particularly the gap between doctors and patients, HCPs and patients, doctors and HCPs and so on, in the ability to communicate effectively and the impact that has on health. And this is the concept of social and cultural capital. Now, again, if you don't quite get this, that's absolutely fine. I would say don't worry too much because this is very much a bonus. But in an interview, it can be very, very nice to show off. It will just make your interview a little bit more different, a little bit more intellectually engaged, and so on. So, there's a significant number of questions which are about some variation of what makes a good communication, where does communication go wrong, what are the challenges of communication in the healthcare setting, basically communication-based questions, which are assessing your understanding of communication. Like all things, any idiot can say they can communicate well. Therefore, how good you do on these statements is not so much whether you say communication is good or not. It comes down to the depth of understanding of communication, that it is implicit, that means shown, in how you talk about it. If I just sit down and go, oh, communication is good, then I've not shown much. If I start talking about concepts such as social culture capital, empathy, and so on, then that will suggest I have a bit more understanding of what communication actually is. There's also a separate range of questions around health inequality. So that's differences in outcomes based on socioeconomic advantage, socioeconomic group, racial group, and so on, and reasons for them. Students struggle with these questions because while students can say that both those things are good and bad respectively, they struggle to be able to explain exactly how and why they are good or bad, and particularly how and why they happen in the first place. And so it's important to think about the how and why, not simply that they are good or bad, because otherwise you're going to end up saying the same answer as pretty much anyone else. This is usually the result of the fact that people don't actually understand how the NHS works, or the role of a doctor works, but sometimes it also comes down to a lack of understanding of what causes good or bad communication, what causes health inequality in the first place. And therefore, the concept of capital is designed to give you one building block amongst many, certainly not the only, but one building block amongst many to sort of be able to explain to an adult for over 5 minutes in your MMI or wherever it happens to be about the nature of communications, barriers to communication, and so on. So it is helpful to first introduce this man, Pierre Bourdieu. You will never mention his name in an interview. Please do not mention his name in an interview, but he's just the background to this. He's a sociologist, and he essentially looked at the fact that that we live in a profoundly social place, but a place where also we're in competition for resources. They can be school places, they can be university places in your case, they can be romantic, they can be whatever. We are constantly in competition. We all want something, not everyone can get something. How do we act in it? And essentially what he argues is in any given field, so let's use the example now, you are actually literally doing some social culture capital now, in that you didn't know this thing. In the field of medicine admissions, there is some knowledge, such as knowing capital, knowing how to answer an MI, knowing about how to do a Section 2 question on UCAT. That is all going to give you an advantage in that competition to become a doctor. So in the field of medicine admissions, there are certain pieces of information which will give you an edge. There are certain skills that will give you an edge. Not because that information is naturally good, it's not good or bad, but because it is because of the nature of what defines the competition, basically what defines who wins in the competition in medicine admissions, the information that is useful is therefore different. If we compare it even to Oxbridge admissions, Oxbridge has very different rules and very different things they look for, and therefore the skills you need, the culture capital you need is very different. Now actually I would say this information is also very useful for Oxford admissions, but if you're doing Oxford admissions, UCAT information, which is vital for the medicine admissions, is not useful at all. For Oxbridge, because they use BMAT, and therefore UCAT stuff isn't really useful at all. And so what essentially he argues is that in any given topic, any given competition, every given field, there are things which are more valuable and some things which are less valuable. And students and individuals have different ways of being able to grasp and apply these. This is called the habitus, your ability to sort of apply these knowledge and work your way through the field. And this is not something ever really taught formally, although I'm clearly doing it here. It's something that a lot of times you pick up. This is often why he explains that middle class people and upper class people do better on these sort of competitions, because they pick up passively from their parents, who are often more middle class, therefore have learned a lot of those cultural capital skills. They themselves then have passed down to their child, and then the child has a slightly more advantageous position. So you can imagine, for example, if you're the child of a doctor, you might have a slightly easier way of getting through some of the questions because you are used to them, even if your parents haven't formally taught you about medicine. And the idea, therefore, is that what people can do is they can take the knowledge they have and, to use this posh word, transubstantiate it to get a material result. So, for example, you are, as a result of this video, hopefully going to have slightly more cultural capital at the end of this. You are going to know something about capital theory. And that means that should, in the competition in the field of medicine admissions, you get a question on health inequality or the communication side of stuff, then you will now have a slightly more advantage than, say, someone who hasn't seen this video. Now, obviously, maybe this one video alone isn't enough, but when taken amongst many other parts of capital, now you can see why it perhaps means that there are differences in outcomes in university admissions. So, what does he mean by capital and cultural and social capital? Social capital are the people you know, yeah, and the people you know who are able to help you in a competition. So, if you happen to know the head of a medical school that you're applying for, if you happen to, I get a lot of people send me emails because they know I do this job, and they say, "Oh, can you go and tutor XYZ?" So that's like a recommendation. I know, I like to think I know what I'm talking about here. We have a very successful results in medicine admissions specifically, therefore, someone who happens to know my school or know me personally might personally recommend me, and that might have more of a chance of me saying yes to tutoring. I don't tutor, by the way. But there's a world where that's more likely because they happen to know me. Also, if you are a well-known name, so for example, if you are the prince, or if you're someone whose dad donated to the medical schools by the wing, again, that's the sort of stuff that could have an impact. Now, this stuff in medicine admissions is already not very big. In compared to other health systems, in the NHS, these sort of things don't really matter, as we shall soon see. It's less about who you know in the NHS. The NHS is a bit too bureaucratic in most cases. Absolutely, in certain cases, it can make a difference. But because you often don't have as much control over who you see, you don't have much control about where you are referred, because it's a very CCG-led bureaucratic approach, social capital is actually not that big a deal, particularly compared to other countries. So, for example, in Korea, a lot comes down, because their system is very decentralized and there's not much, it's up to the patient to navigate through doctors. Recommendations and networks are huge, because if you know the right person, they can get you in with a doctor that they went to PNU with, for example, or they went to Seoul with, it's a Seoul University in, and then they'll be able to sort you out from there. And there's definitely goes on there, and there are other health systems as well. When it comes to communication, health and equality, therefore, we're far more interested in cultural capital. Cultural capital basically means knowledge, ideas, thoughts, stuff in your brain. Now, sometimes it can be full on, like, I fully understand the signs of cancer. It can also be how to talk. It could also be to understand how doctors like to be spoken to and how they do not like to be spoken to. And also understanding about how the health system works in the NHS generally. And the idea is that through this level of this knowledge, this performance, the rules of social interaction, particularly of doctors, and the understanding of the NHS more broadly, people who have different levels of this, depending on different levels of exposure to the media, different levels of exposure through parents, their academic understanding, and so on. And what that means is that often you have two patients going to the same health system, maybe even the same doctors, but might have the same symptoms, but they might have different outcomes. Because, for example, this patient might know more about the health problem and be able to explain it better. They might know how to explain medical concepts and, for example, know the difference in a throbbing and a stabbing pain, and understand what the doctor means about it, and therefore be able to say the right thing. They might also know how to present the information to doctors. I'll mention this later, but when I ever go and see a GP, I know exactly what I want, right? And so you go in with a mentality of, right, how am I going to persuade this doctor to refer me? How am I going to persuade this doctor to give me the X, Y, Z? And so you don't go in with like, oh, let's just mansplain my symptoms and see what they say. You go in with a strategy because you know that doctors will sometimes not refer. They go on a gatekeep. So you've got to go in and wait. So for example, you can't say, oh, I Googled it. Even if you did Google it, you don't say you Googled it because you know they don't like it. That's me understanding rules, social interactions. Likewise, if I understand that like doctors don't like to be spoken about a certain way because they like to be viewed as a professional who have autonomy, or are suspicious of certain types of patients that present a certain way, I'll avoid presenting that way. And likewise, if I understand the NHS and how it works, I'll be able to better understand and push for certain areas, certain things, and use certain frames. So, for example, I have very good knowledge of the current vaccine policies for reasons I won't go into. I can then use that to leverage when a GP says X, Y, Z. I can say, well, actually, no, like that's not the case. I know for sure that blah, blah, blah. And normally that can get your way if it needs be. So the idea is that actually, to succeed in the medical health system, because medicine is so much based on communication, diagnosis, but also referral, also working with through the health system, communication is key for me getting across what's wrong with me. You getting across to me what I need to undo in terms of how to manage my health care. Me about how to approach managing my healthcare as I go through the NHS, for example. Knowledge is key. Performance is key. Understanding how to perform is key. Understanding the theatre and the arena in which I'm performing is key. Essentially, because medicine is not a science, it's at best an applied science, at best, and I'm even dubious about that characterization, then the social part of that means that certain people will have different abilities to be able to socially perform based on the knowledge and understanding of the rules of medicine, rules of the game, and therefore there'll be different outcomes. So, we'll talk about cultural capital in a second, but just so we understand, in many ways, social capital, that sort of the who you know, has been sort of deliberately limited by the NHS. It's quite hard for you to go, you can't just tip up and say, I want to see this consultant, right? You're going to be referred by a GP who has this form, who may not know you. There are rules about who they can refer to, and etc., etc. There's lots of rules, so it's very bureaucratic. In addition, you can't just suddenly say, I want to go to the other side of London. You are given a choice, but it's a limited choice. And so this controlled choice of like, yes, you can choose between St Mary's or Babum, but in reality, if someone you know is in another unit hospital, the fact that you know them is not going to help you. There is, however, still maybe what we might describe as a soft economy. It does make a huge difference, but it probably is there, where you might be able to recommend a particular doctor, which means that if you have a choice between two places, but you know XYZ doctor is good, then yeah, you might be able to go there. Likewise, in certain cases, it is not unheard of for consultants who are gods in their departments often to pull some strings to make sure the right person comes to them. Often they will only do it for really close people because it is unusual, but it's not unheard of. And likewise, networks of sort of knowledge, networks of, you should speak to that person, networks of, this GP practice is better than this GP practice. The sort of things, conversations she middle class, sort of coffee dates, talking about, it still exists, right? And that might have an impact. Let's say, for example, in the middle class community, there's two GP practices, and the gossipy middle classes say, actually, this one's better than this one, and everyone hears about that one, and it is better. But the people who aren't part of those middle class communities, who don't share this information, are unaware of this, so we'll apply 50-50 for the good one and the bad one. So what you'll see is the middle classes, therefore, proportionately will be more in the goody one, whereas the lower classes will be more evenly distributed. That could have, on a population level, a knock-on effect on overall outcomes. On an individual level, probably not. On population level, probably. So social capital can have an impact, but I'm really don't really want to emphasize this, because actually you're going to cause yourself more problems trying to explain how and why if you don't fully understand it than not. And there's a lot more to talk about cultural capital, so we're just going to move on to that, to be honest. So there's lots of different ways that cultural capital has an impact. We have hopefully been introduced to the concept of health literacy. If not, it's a very useful term. Health literacy is your understanding of healthcare and the health system, which you will then mobilise in managing your health, your treatment, and your journey through the NHS. So, for example, it can be health literacy can be identifying symptoms. So, my wife previously worked in cancer recognition, symptoms which are associated with cancer, and then symptoms what percentage chance that someone recognises it's cancer, both for GPs and patients. Different people will have different levels of understanding of what a symptom is, and if that's a bad symptom or not. If you are more health literate and you have greater cultural capital and knowledge, healthcare knowledge, then you are more likely to recognise symptoms that are really important, and what we might call alarm symptoms that suggest there's something serious going wrong, and perhaps even an urgency. So there's certain symptoms, the fact that your heart's having difficulty, which some people will recognise because they have literacy about it, others do not. But if we then take that on a population level, so maybe on the individual level that does make a difference, but on a population level, if you have Group A being more able to identify quickly a symptom of cancer, and Group B not less able to identify quickly, Group A is more likely to get treated and seen and go to the doctor earlier. That means they're more likely to not have the cancer develop or the heart attack actually happen, which means they're less likely to die. So on a population level, now this is starting to explain perhaps our inequality in outcomes. Because so much of healthcare is reactive. It is up to the patient to go up to the doctor and say, I've got this problem. But you need to know that XYZ is a problem, and often a serious problem worth actually going to the GP about, in order to be able to then both go to the doctor and explain it to the doctor. So what we can see is actually what tends to happen is because patients lack that knowledge, they tend to wait and delay, despite the fact that they had symptoms, until they explode. In addition, there's a form of health illiteracy called fatalism, where patients often don't want to face their the fact that they've got XYZ condition, or will think there's nothing that can be done about it anyway because they don't understand the nature of the condition, and therefore don't seek help even when they identify the symptoms. So for example, someone sees something, they go, oh, the doctor can't do anything about it, they won't go and see the doctor. Or they don't want to, their parent died of cancer, they don't want to sort of acknowledge the reality that they might have cancer, so they just don't see the doctor. It's a classic avoidance strategy. Do not judge patients too harshly if they do this. In addition, health behaviours, that's smoking, drinking, and so on, and unhealthy positive health behaviours, and healthy health behaviours such as running, eating five fruit and veg, etc. That stuff, again, is based on your knowledge. The more you know about how to do it and what is good and how it is done healthily, the better it is. And finally, a big thing, when I go to the doctor, if I've got 5 symptoms, I know some of these will be quite generic. A cough, a high temperature, and I know that the doctor will be like, that's really not very exciting. That could be a amount of things, and they're not going to worry too much about me if I come up with that. So if I'm able to go, well, I know that this is a symptom that they're going to find sexier. What that means is that they find it much more. That must be serious. About it, then I'm more likely to be taken seriously. So I don't lead with the cough. I don't lead with the sort of high temperature. I might say, when I breathe in, I get a stabbing pain. Something which I know that's something that's more likely to get their attention. There's fewer things it can be, and it's usually more serious. So because I understand what problems are worse, what problems are more alarming for the doctor, and might make me be taken more seriously, what ends up happening is I end up playing up to that, and I end up deliberately choosing how I present and what symptoms I do present within that in order to potentially get an edge. Now, it might not make a massive difference on a person-by-person basis, but if I have Group A, who are always identifying the most alarming, most attention-grabbing, and most likely to be taken serious symptoms first, and then putting the others in the background, compared to Group B, who are talking to their GPs, and they might list from generic ones. By the time they get to stab, it's sharp pain breathing in, the doctor's already half bored, or it's probably a cold, and therefore will confirmation bias, not listen to it as much. What will end up happening is I'm on a statistical level, even if it's only by 5%, I'm more likely to get referred in Group A than Group B, and on a population level, statistically, that might lead to outcomes that there's a 2% higher rate of dying in Group B, for example. Okay, so what we're saying here is knowledge is power. Knowledge, the ability to identify, is key for a health system which is very reactive, and knowledge is also important for how you behave and present the information to doctors. In addition, the NHS is a deeply complex machine with lots of different parts. If you understand the NHS and how it works, the different bodies, the different roles, you're better able to navigate your way through it. So you know where to access, for example. We see a lot of patients will go to A&E when they shouldn't go to A&E, and that's not just bad because it's bad for A&E. They won't get treated properly there. And actually, that means that their outcomes will be different. They'll be lower. They will do less good health-wise. So knowing where to access. Also knowing what doctors can and cannot do. So we'll describe as disciplinary knowledge. The discipline is like doctors, the professional knowledge. If I know what doctors can and cannot do, what the difference between a consultant and a registrar is, I can therefore start playing that to my advantage. In addition, if I understand the culture, if I understand how for some degree the NHS should work, I can be more confident and more quick about when things go wrong. The NHS constantly loses patients, constantly forgets to refer people, constantly doesn't do X, Y, Z. If I understand what should be happening, how long it should take to be referred, and so on and so on and so on, I'm more confident, more aware that something's gone wrong, and therefore I'm going to be quicker to deal with it, and therefore more likely to get seen quicker, and therefore that might have an impact on health. In addition, if I understand the differences between different HCPs, healthcare professionals, then I'm more likely to be able to use that to my advantage in order to get to the doctor I want to speak to or the specialist I want to speak to, rather than just saying yes to the first person who comes. And finally, if something goes wrong in the health system, I'm far more likely to identify what's caused it, and therefore far more likely to be able to solve where something goes wrong, be it a referral's gone wrong, be it that the doctor's not in and therefore I can't be seen for XYZ time, and if I understand the NHS. So once again, this might not make a difference on individual cases, but you can see over in a population of 60 million, if Group A, and obviously it's a lot more complicated than two groups, but for the sake of argument, Group A understands where to go, understands what to say, understands like what key words, what key symptoms, what key vocabulary makes sense to the NHS or doctors, understand how the system should work, understand which doctors I need or which specialists I need to see and why, and understand how things might go wrong. On a population level, I'm less likely to have a bad healthcare experience, which means I'm more likely to be able to be seen quicker, seen by who I need to be seen, and have any issues resolved, which means I'm more likely on a statistical level, even if it's 5%, 10%, to have better outcomes. Okay, it's well worth looking up the Marmot report into health inequality. He talks a lot about, Marmot report to health inequality to COVID. Talks a lot about how a lot of particularly these problems lie at the heart of and why there's such inequality in COVID deaths between races and socioeconomic groups. In addition, all social interactions, all the conversations between doctor and patient are mediated by cultural capital. Okay, so we've always seen health literacy, how you present your symptoms, how you know to identify which symptoms are more serious than others, and how to say, well, I tried this beforehand, so the doctor doesn't then say, oh, try this, and then tell you to go home. Okay. As a doctor, you cannot feel the pain, you cannot feel the symptoms. You are relying on someone to explain to you what is happening in their body. If the person has the words and has identified the symptoms and has the ability to explain precisely, so if I say it's got a stabbing pain rather than a throbbing pain, I know what the difference is, then I'm going to be better able to articulate what's wrong with me. And therefore I'm going to be better able to make sure the doctor understands what's wrong with me, and therefore more likely to be successfully diagnosed. If I struggle to explain the terms and the symptoms, not just the symptoms, it's the terms, then as a doctor I'm less likely, statistically, even if it's by 2, 3, 4, 5%, less likely to be able to diagnose correctly or quickly, and therefore less likely to be able to then treat the patient effectively, and therefore there's a higher chance the patient might die. Let's say we have two patients. Patient A fully understands what is the symptoms of bowel cancer, for example, identifies them, identifies which are the most serious, knows what they need to say they've done beforehand in order to so the doctor doesn't just say, I'll go away and do the X, Y, Z. They tip up, they know exactly with all the information already, what to say, how to say it, and what so that they get referred quickly. Whereas a patient who doesn't understand the symptoms might just say, oh, my tummy hurts. Oh, I had this, and doesn't know what's unusual, and therefore there's a higher chance they might be misdiagnosed. In addition, if I understand how doctors like to be spoken to, because then that's knowledge. If I know, I know because I have a lot of doctors in my life. I know a lot about how doctors like to be spoken to and don't like to be spoken to, often from stories about when the patient spoke to them poorly and they reacted poorly. If I know that, which is cultural capital, I can then be a bit more proactive, right? I go in to see my GP with a plan of what I'm going to say, how I'm going to say it, and I'm managing the GP as much as the GP is managing them. Not everyone has the knowledge of doctors, of the culture of doctors, how doctors want to be spoken to do that, and certainly do that successfully. So being able to manage doctors, particularly this is a variation in culture and race, where doctors overwhelmingly are privately educated white middle class people. They have a way of speaking, they have a culture of speaking. It's not better than any other culture of speaking and acting and behaviour beyond, but it's theirs. Therefore, obviously, if you are also white middle class, you're more likely to be able to speak in that way and that navigation. Whereas if you're not, if you're from white working class background up north, you're gonna have a slightly different way of rules set about how one communicates, and that might not gel as well. And that might have a knock-on effect. So, for example, doctors don't like it if you're too direct in how you speak, and some cultures are more direct, not because they're good or bad, because they're different. So the idea is that how you navigate and how you work with doctors and how you work through them isn't chance and isn't random. It's socio-economically linked, culturally linked, and that will have knock-on effects for your outcomes. You're also better able to pick up on the social cues, pick up on the social mores that the average doctor has because you're more familiar with them and therefore be able to play them. We've all had situations where someone has not been impressed or fully understood us because we did not necessarily communicate very effectively with them. Often that's because we have two different what we call frames of references. Frame of reference is your understanding of how to communicate. If we have different frame of references, therefore we're going to might struggle a little bit more than if we have the same frame of reference. That's why you always find it much easier to communicate and work with people who are friends you've spent a lot of time with or are similar to you or have similar life experiences to you, and so on. So what these all three areas are, there's a lot more, is essentially the idea that actually, although obviously people's bodies are very similar, because a lot of medicine relies on communication and proactivity on the role of the patient, differences in knowledge, what we described as cultural capital, of performance, of symptoms and so on, can have a real impact in outcomes. And therefore, when we're looking for how doctors should communicate, they need to be much more aware of this gap and how to navigate this. So for example, if you're a doctor in a poorer area of a different culture, you need to be more proactive in identifying the gaps in cultural capital that patients might have and be able to proactively manage the gap therein. For example, if you know that patients are going to have less health literacy about explaining symptoms, you need to be much better at helping guide them and much more attentive to be able to sort of explain to them what symptoms are good or bad and making sure you're pumping them for information a little bit more because you can't rely on them to do it themselves. It's something which you can't fix, however. It's fundamentally based on the sort of stuff you passively picked up on the world. However, through schooling and health education, through putting systems in place to be able to better train patients, particularly primary care systems, as well as systems in place to sort of like checklists of like making sure you go through a big long list of potential symptoms and the patient suddenly goes, oh yeah, I do have that. Okay, that's quite serious. That sort of thing, you can argue that's really useful. In addition though, and I think that for an interview you need to make very clear, a lot of this starts with the individual HCP, the individual doctor. If you understand that people have different social and cultural capital, particularly cultural capital, and that to some degree, although yes, it'd be great if the NHS sorted it, it'd be great if the education system sorted it, it's unlikely to in the short term at the very least. What can you do as an individual doctor to mitigate the problems? So, for example, I often use the example of my grandfather. When he was alive, he's a white working class man from a rural background. He does not admit pain. You don't, in his generation, his people men do not admit pain. So if he turns up to a doctor and says, I'm in pain, and in his world, that is huge. And that has a huge capital value. Unfortunately, the doctor was not from his class, so just saw an old person saying they're in pain. My granddad then spoke in a very working class direct way about how he needed to see a doctor. That doctor did not react very well. It escalated. He ended up getting, getting sent home saying it's fine. He then came back and said no, because he's my granddad, and turns out he had very serious cancer. It was treated, and he's lived for another 16 years. Had he not, that could have gone very differently had he not had that final level of bolshiness, because of a gap of communication. Because he didn't have this health literacy to be able to explain in more complex terms precisely what the nature of the pain was, because it was a very weird form of cancer, which he found it was very difficult to explain. It wasn't on any particular organ. So in that case, that was very close, near miss. Now, a lot of this won't make a difference either way. Doctors work very hard, patients often have very obvious symptoms, but when we're talking about health inequality, we're talking about a 10% difference in most cases. And you can see how between these things and other factors as well, this adds up. Thank you very much for going. Hopefully that's been somewhat useful. Next session we are doing, I believe, healthcare professionals, but I will see you then. Enjoy.